introduce ourselves briefly, my name is Jenny Walker. I'm a dental therapist based in the Northwest. And my experience with implants is that I work in a peri-implant disease referral centre. So I get a lot of implants referred into us from general practice in the local area who are struggling maybe to manage with peri-implant disease, or the patient doesn't have a supportive team in the practice they can visit for their supportive care. So we do see a high number of implant patients, and most recently took part in the S3 peri-implant disease treatment guidelines alongside my colleague Kathryn, who is next to me now, and I'll let her introduce herself.
I pretty much work in the same kind of setting, really. The slight difference being I teach undergraduates, so I teach Manchester Uni undergraduates, everything around implant maintenance. So they will start from the beginning before the implant's gone in and run right the way through until the patient has had the implant and has had their baseline charts taken and things like that. So I have like a slightly different experience there. I do a lot of private implant work as well. So I see a lot of implantitis. And here where we are at the moment in the Northwest, we see lots of referred patients in for implantitis. And to be honest, that's only increased. I've been working here for 7-8 years now, maybe longer. And that has really increased hugely, probably due to the fact that lots more implants are being placed. And obviously, we're quite involved in education and educating the dental team to make sure the patient gets the longevity out of their implant, really.
Yeah, most definitely. I think we from my experience of teaching on the MSc, so that's the course where the dentists learn how to place the implants. We stress the need for teamwork in the implant approach. It is a whole team's responsibility, really, to get the patient from start. And there isn't really a finish because the supportive care is lifelong. And we do spend a lot of time with the MSc dentists educating them on the importance of that supportive care, but also before the implant goes in, getting things right before. So periodontal assessments, risk assessments, full consent of the patient's fully aware of what they are about to embark on the implant journey, stuff that we really believe is important to be there from the outset.
Yeah, definitely. I think that we also are involved in some medical legal cases as well, and one of the biggest things that we see is that patients haven't been informed prior to implant placement about maybe their risk or their what they need to do to prepare, and also their commitment, really. I think that lots of patients, because education isn't there for patients, they think, oh, I'm having an implant, so it will just look after itself, where actually our message is, this is a great solution, but it needs a lot of work in terms of you coming and us monitoring. And as Jen said, that initial preparation is absolutely key to that longevity of the implant, because once the patient knows what they need to do, they will be in a situation where they're armed with the tools to be able to do it. And it works for the dentist as well, because obviously the dentist will have happy patients coming back in with very few issues. So, yeah, we're very big advocates of let's get that message to the patient before they actually have the implant placed. And then, Jen, you do quite a lot of with the patient whilst they're actually having that journey, as I do as well.
Yeah.
So what would you...
So I'd say one of the most common things, a lot of patients will come to us as periodontally susceptible. So there's a reason they've lost teeth, especially if it's multiple teeth and the patient wants a full arch of implants. We really need to establish how the patient lost their teeth, because if it's through periodontitis, then we need to make sure this patient is managed in a certain way. And just because a patient is going to have all of their teeth extracted or failing dentition taken away for the full arch prostheses to go in, doesn't mean they are no longer periodontally susceptible. We know that they are for life. So that patient then needs to be educated on that. We're not trying to put the patient off having the implant work. We're trying to empower them so they know that their risk is there, which means that they are more likely to attend their supportive care once the implants have been placed. And what we know from research is that supportive care reduces the risk of peri-implant disease. So it's about 50%, isn't it? 50%. So patients who have supportive care have a 50% less chance of getting peri-implant disease, which is quite a significant statistic. So when our patients come into our clinics, we assess them first, and one of the first thing we'll do is a periodontal assessment on the patient. And I have to say, in my experience, when we do get implants referred into us that are having problems from other areas, one of the common findings is that these patients haven't had periodontal stabilization prior to the implant work going in.
Yeah.
So that's something that we're really keen on managing well before any of our patients go on to have implants.
Yeah, definitely. And I think that once we've done that, once we've got them at that situation, it's quite easy to engage the patient because they want the implants. And it's not about let's hold you back. It's about actually we need to reduce inflammation in your mouth if there is any, and make sure that your bleeding is really low, so under 10% is ideal before the implant goes in. But that can run alongside the implant treatment, and we were supporting the patient throughout that. So even after surgery, so things like using a soft toothbrush for a couple of weeks afterwards, maybe not using an electric toothbrush, hot salt water rinses, making sure the patient has they're taking the prescribed medication. Some dentists prescribe antibiotics, some don't. But really just being there as a support for the patient and making sure that sometimes if you're taking a staged approach to implants, it can be quite protracted, the amount of time that the patient is in a situation where they're having treatment. And we as hygienists and therapists shouldn't drop off at that point. That's where we're there to sort of really help the patient and keep them engaged. And then once the crown or the full arch or the prosthesis, whatever's going in there, is in, that's when we then kick in then for sort of explaining how this differs, how brushing may differ, what different types of oral hygiene aids might be appropriate. And then around sort of the 3-month mark, after they've had the restorative work placed, we would then start to do our monitoring process. So we spend a lot of time talking about this, don't we?
We do. So the monitoring is key, really, because what we want to do is make sure that we are looking out for any early signs of peri-implant disease. So once the patient has had everything fitted and we've got final restorations on, we want to have an appointment with the patient to collect our baseline data so we know we can monitor the implant long term. And that will include a baseline radiograph, which is often a PA of each implant. And we'll take a 6-point pocket chart of each implant, and we'll also note any bleeding that occurs. And also a key point is, how is the patient managing the biofilm around the new implant work that's in there? Can the patient manage the biofilm? Because at that point, if we don't feel the patient can, we will liaise with our dental team to make sure we get the best outcome for the patient, which may actually be having some alterations made to the prostheses, which is generally in the patient's best interest, really. We're very lucky to work in supportive teams that will do that with us, and we work together, really. And that will increase the longevity of the implant work. But going back to spotting early signs of disease, that's where it's key that the patients do attend regularly. We'll often see our implant patients every 3 months. And that's where at each appointment, we will probe our implants and we will assess for any bleeding, and we will clinically and visually check for any signs of inflammation or any changes to the tissues. And we also palpate all our implants to see if anything has changed at all. Because if we are seeing early signs of disease, if we can get in there and we can get that reversed, which evidence tells us mucositis is reversible in most cases, then we will prevent that progression to what we don't want, which is peri-implantitis, which is extremely difficult to manage.
I think at that point as well, we would always 99% of the time, we would look at how we are then going to do our PMPR on that patient. We would look at the diagnosis. So we would formulate our diagnosis, as Jen just said, by all of those key points that we would look for. And then we would decide what we are going to do in terms of what mode of instrumentation are we going to pick. And I would say this has really evolved over the time I've been working with implants. from when I first started working with implants, I generally only use hand scalers, titanium hand scalers around an implant. And I would, even if I felt the implant was healthy, I would still just sort of do a little bit of a sweep round because I felt that's what I should be doing. And possibly myself and other people maybe were over-treating implants. I think if an implant is healthy, why change what's there, you know? And this is where air polishing comes in, because air polishing will evoke the least surface alteration. It's fantastic for sort of access, for getting round and underneath prostheses and bulky implant work, which is not bulky because it's substandard. It's bulky because that's the nature of implants and how they contour and the morphology of them. But it's quite a challenge for us as hygienists and therapists to be able to get in and around these prostheses and this crown work. And like I say, this is where air polishing really does sort of come into its own. When you've got the soft powders, you are able to sort of make sure that you're getting into these areas and you're not traumatizing any tissues, and you're really not causing any issues that may be detrimental to the implant. We pretty much use air polishing on every patient unless they're contraindicated.
Most definitely. And I think from patient feedback, because obviously when we started, we didn't have the air polishing kits, and then we've evolved to have air polishing kits across all our clinics now with our implant patients. Patient feedback has been very positive. In a sense that I would say it's even increased our recall and compliance, because patients find it more comfortable. And I think that's really important in the clinics, to make the patient comfortable. We don't want the old-fashioned dreading seeing the hygienist or therapist. The patient generally walks into the appointment and knows that it's going to be quite a comfortable visit. And I think that's essential, really.
Yeah, definitely.
Yeah.
I think it gives us something as well, because we didn't have or air polishing wasn't indicated before because the powders weren't there. It gives us something where we can actually disrupt biofilm, which gives the patient a bit of value to the appointment as well. Because if we weren't using the air polishing system, from our point of view now, because we wouldn't want to change the surface of the implant, we would use oral hygiene aids. We wouldn't use a hand instrument or an ultrasonic at this point in time. I think then we would move on to mucositis, and mucositis, we would be a little bit more aggressive in our approach, but it's still very much disruption of biofilm focus, so very much what the patient is doing, remembering at this point that the mucositis is reversible as long as there aren't any plaque retentive factors. So we may air polish at this point, but also maybe just sweep round with a hand instrument to check for any cement, if it's cement retained, prostheses or crown. But we're still being very, very gentle to those tissues. We're being very careful that we're not causing any trauma. So again, with the mucositis, we're really looking to try and get that back to health. So we're trying to make sure that there is the least surface alteration as possible, really.
And then obviously once when we've got a mucositis case in front of us, we will attempt to treat that twice before we will then refer that back to the dentist, because we know it's really key to get it right first time with mucositis. There's evidence out there to say that the first input of treatment is really important. So having reliable kit there in the surgery is really important. But when we are unfortunate and we have implantitis in front of us, which we do see more frequently in our referral centres, that's when we have to take a different approach to the implant, and when we're looking to debride the implant. Mm-hmm. And that's when we'll use other pieces of kit, such as our titanium instruments. We will, in some cases, use our ultrasonics, certain tips. So it's really important that if you do have an ultrasonic kit there, that you do have different tips that are more adaptable to the implant surface, and ultrasonics that can be turned down in power as well, because we don't want to be put full power ultrasonics onto those implant screws or threads, because yes, we'll change the surface, and no, we don't know what that will do. There's no evidence out there to say what that will do, but we don't really want to be changing the surface too much of those implants. So it is important, if we're going to be starting to manage implantitis in the clinic, that we do have the right kit then to support us getting the best results really for the patient.
Yeah, definitely. I think I found using the P's-on with an angle tip, there's some great tips out there now, and that angle really helps to sort of you to get into the thread of the implant if you've got to get in there, because it's a risk versus benefit situation. Yes, you will change the surface because it's an ultrasonic, but it will hopefully disrupt the biofilm and get the patient into a healthier situation. So I really like using these angle tips, and they're very much like the titanium scalers we use. And the titaniums, even though you can use stainless steel, they're just designed in a better way so that they can come round the sort of, in inverted commas, screws of the implant, and get into those threads really, really well. And in terms of that, that's the treatment for implantitis is very much patient-led. We know that we don't have a reliable way of treating implantitis. As it stands, there isn't a sort of an ABC, and it will give us a reliable outcome. So it's a bit like try everything and see what works. In terms of the new S3 guidelines, which are about to be hopefully adopted by BSP. We are looking at certain modes of instrumentation depending on the diagnosis. So when we're looking at health, you can use pretty much whatever you want. They're not really prescriptive there. With mucositis, they are looking at evidence sitting with what we call single modes of instrumentation. So either using an air polisher or a hand instrument, but not a combination of the two. I would say the evidence is quite weak here. So this is going to be a little bit transient. It's going to keep moving. And I think we're going to have to keep our eye on the evidence. And then when we're looking at implantitis, we're a bit, as we just discussed before, anything goes really, because it's a risk versus benefit. So it's already diseased. It's already what we call oxidizing the implant surface. So when we put our more heavy duty instruments there, it's hopefully not going to make that much of a difference, because we're going to get it clean, and that's the aim, really.
That's the goal, like full decontamination of the implant threads and the collar when we're dealing with implantitis.
Yeah. And we would generally, for our protocol, we have a practice protocol. Jen and I have designed a protocol. We would see our implant patients, everybody, in the first year to every 3 months. And that's, as Jen said right at the beginning, is about how's that implant going to fare in that patient's mouth? How's the patient going to be able to get on board with cleaning it? Because it is a little bit more of a challenge than your natural teeth. And it just gives them the support that they need. So that's our protocol. And then moving forward, at 1 year, we would take another radiograph, look for any bone remodeling, and then we would look at risk assessing the patient and see where they need to be ongoing. And we always say to our patients, that's a little bit transient, so that can be, maybe this time you need to come in 6 months, but, if we look at that next time, we may need to see you in 3 months. And what we're doing is really looking at monitoring and intervening really quickly if there are any issues with the implant, and getting across to the patient that we're there to monitor. So when that implant's healthy, the amount of actual cleaning, in inverted commas, that we would do is very, very minimal. It's all about seeing that patient, to monitor them, to intervene really quickly if we see any signs of disease.
Yeah, most definitely.
Yeah.
I think it's also a good tip as well for clinicians who are treating implants regularly, to maybe consider disclosing their patients, so they can show their patients where the biofilm is, and then get the patient to remove the biofilm in the clinic in front of them, so they can guide them on how to do it. Taking videos for the patient as well, because often implant work is quite difficult to see. I personally use an intraoral camera to take shots of where they need to maybe improve their cleaning, or some of the awkward areas around implants, so we can get it up on the screen and show the patient. But also maybe giving the patient target scores as well. So if the patient's falling down a little bit, it can often be because they're struggling. So giving them some advice, a target score, and then when they've improved the next visit, it's just a good incentive for the patient to keep going, because you know what, it can be tedious, some of the tasks we set our patients, and some of the cleaning aids that we get them using, it can be a little bit tedious for them. But I think if they know that we're happy with how they're progressing, and that's a big incentive for them, that they'll keep their implant work longer, then they most often comply.
Yeah, definitely. I think implant, that they're a lot, it's a lot of money. They're giving a lot of their time and a lot of their finance to this situation. And we as clinicians need to make sure that we're supporting that for the patient. Some patients are financing, to get this work. And we know now from, sort of a systemic disease point of view as well, keeping your teeth for longer is actually really good for your general health. It's reducing non-communicable diseases. There's links to things like Alzheimer's disease, and Jen spoke about that recently in one of her webinars, and she can probably give you a little bit more idea.
Yeah, so the biofilm that exists within the oral environment, it actually triggers that inflammatory response, which we all know about. But that actually affects distal sites in the human body. So we've got Alzheimer's disease, cardiovascular disease, respiratory problems, diabetes. And I think at the moment, statistics are that there's 67 conditions being investigated to be linked to periodontitis. But we've also got to think about peri-implantitis now. If that's becoming more frequent, then that will also be having its impacts, because it's an inflammatory condition. So it's educating the patient that this inflammatory problem is not just contained to the mouth. We don't want to scare the patient. Again, it's about empowering. So we're letting the patient know that if we can try and maintain the inflammation and reduce it and hopefully stabilize it, it's going to impact not just their oral health, but their general health will be improved as well. And I think that's a massive incentive for us.
Definitely. I think with using air polishing as well, air polishing is targeting the biofilm. It's targeting the bacterial sort of maturation, as it were. And it's a really good non-invasive way of getting in and around all of the dental work that the patient's got there, whether it be crowns, implants, bridges, natural teeth, with these sort of sub powders that can be used anywhere. It really does target for the patient. So, I had a patient in yesterday who's had a stroke, and he does struggle, as patients do. And I think when we look at implant patients long term, as people are living longer and they're able to finance having implant work, and with the research in that patients who have less natural teeth actually do tend to be a little bit more susceptible to these other systemic diseases. Patients are going to want to sort of replace. There's some research about what we call proprioception, which is what you feel and how you bite together, and how that can, the messages that sends to your brain. And all of this is really, really linked. So it's just really getting the patients on board, and us having the right equipment to be able to support the patient, and the patient having the right education, really.